Good evening and welcome to On Call with the Prairie Doc. We all have our favorite foods or remember a great meal with friends, but when our digestive system isn't working as it should, our quality of life can be compromised. Problems with our stomach or colon can be as basic as making us uncomfortable for a while, or they can create a profound effect on our lives to the point of a deteriorating lifestyle or even death. We answer your questions as they are called in or sent to us via Facebook or email. Should there be more questions than we have time to answer during the broadcast, we'll continue live streaming on our website after the show in our after hours portion of the evening. Call in your questions at 1-888-376-6225 or email us at oncalltv.org and click on the question button. Tonight, to assist us in addressing issues of the stomach and colon, we're joined by Cristina Hill-Jensen of the Avera Medical Group Gastroenterology and Tim Ridgway of the Sanford School of Medicine in Sioux Falls, both in Sioux Falls. Thank you both for joining us.
Thank you for having us, Rick.
I love to think about how you were a college student doing a special honors course, had to do some research, and you shadowed me for a couple summers.
Yep, a couple summers, 6 weeks. I did the ACP, spent a 6-week course with a mentor, and then loved it. And loved all those colonoscopies you did. Yes,
I mean, maybe that's what got you here,
yes,
I thought.
Yes.
And you did research on...
We did on hospice.
Hospice.
And that was a wonderful paper. That was fun.
And I refer to it all the time.
Yeah, I do too.
I thank you. So you went to med school where?
University of South Dakota, the Sanford School of Medicine.
And then you did your residency?
Tulane University in New Orleans. And my fellowship started there, but Hurricane Katrina stopped it, and I ended up at the University of Iowa.
Wow. See, that was a good exposure, though. You had a different exposure.
Yes, yep. Make lemonade out of lemons, right?
Yeah, there you go. So, and you're back to South Dakota.
I am. Yep,
for how long?
It's almost 8 years.
8 years. I thought it was just yesterday. You were my college student
That's
friend.
my past.
So Tim, you are really probably professor of medicine more than almost anything, right? How much teaching are you doing?
Well, I do a lot of things with the medical school, Rick. I'm oversee the faculty affairs of the university. I'm the campus dean of our Sioux Falls campus. So basically, I oversee our third-year students' clinical opportunities. And I still teach. I love going down to Vermilion, giving the clinical aspects to teach our students why they're learning the fundamentals and why they need to do it. But in addition to that, I'm still practicing.
You're still practicing?
I'm still practicing.
And there's no time left for your family and you. And
you always have to find time for that. It's all about balance, isn't it?
Yeah, it is balance. And where did you train?
I did my medical school as well at the University of South Dakota. And then I did my internal medicine residency at the Mayo Clinic. And it was there where I got turned on to gastroenterology. They just had an incredible group of young gastroenterologists. And here I am. You know, people ask, why did we choose gastroenterology? And I think it's because of associations of people that were our mentors, and we wanted to be like them.
Yeah, there's my hero. I want to be like that guy or
exactly.
gal. Yeah, I think that's what brings us to us. So this is an important issue. We are looking for your questions. I'm not going to beg for them. I don't want to beg for them, but I want you to know that this is your show. So 1-888-376-6225, or go to the internet and catch us. This is an interesting topic. We're going to just take all stomach, esophagus. I mean, the beginning of the GI tract is at the lips, and the end is at the anus. Any in between is fair game, right?
That is right.
Absolutely.
So what would be the most common question you think that people have?
Well, 40% of my office visits are about bloating. So I have a lot of bloat in my clinic, and I don't know if Tim has that. So I think we'll get some bloating, some reflux tonight.
Okay, let's hit that. What is it that causes bloating? I mean,
well, it can be quite a few things. I mean, first of all, people when they eat, you suck in a lot of air. But
swallowing air.
Yeah, exactly. Excessive gas.
A nervous habit is swallowing air?
Yeah, it can be, and gulping down food, maybe not taking time to dine, perhaps. But it also can be related, and what we talk about in clinic a lot is, you know, as you kind of alluded to in your intro, you are what you eat. And so we work a lot with diet, talking about ruling out diet, as long as we make sure there's nothing else going on.
Well, there's a lot of problems with milk. There's recently just all this rage about gluten and celiac disease.
Absolutely.
How often do you see a milk problem or gluten as a cause of this bloating?
Yeah, well, gluten, celiac disease, 1 out of 100 individuals. We used to say 1 out of 126 Caucasians, but now newer studies have said, nope, it's 1 out of 100 here in the United States. The lactose intolerance, as Caucasians age, about 4 out of 10 will become lactose intolerant. So these are...
I mean, you know, you're a little kid, you can tolerate milk, but you get older, you lose that ability.
Lose that enzyme. Yep, you just can't tolerate what you used to. And so some people say, well, I just, you know, I eat a bowl of ice cream, I'm uncomfortable, or I have my cereal in the morning, and by noontime I'm struggling.
And how about not enough fiber? I mean, is that a cause for bloating or
well,
causes
sometimes
bloating?
Too much fiber, and then we get individuals who say in February or March have been on the very wonderful healthy diet. They're eating all the right fruits and vegetables, a lot of fiber, and sometimes too much fiber can be a problem as well.
Okay. Tim, what is your most common problem that we...
Well, you know, I'm do a lot of endoscopy at the VA Medical Center, and one of the timely things that has just been in the news, and I think maybe many of our viewers are questioning about, I get this question at least once a week, and that is this issue of infected endoscopes, where they have passed on infections to their patients. And so these patients come into me, and it's either a family member or the patient that says, what is my risk for getting a serious infection from one of these endoscopes?
Yeah, and what is the risk?
Well, it's important that our viewers know that for the standard procedures, colonoscopy and upper endoscopy, that risk is not there. The problem was in these special procedures we do called ERCP. And we use a special scope called the duodenoscope. And with that, there's a little elevator that we use to lift our little plastic tube to put in the bile duct. And it was that little device that was not being cleaned thoroughly that has led to these outbreaks.
So now an ERCP is when the scope goes in through the mouth, down into the small intestine, and then they look into the pancreatic ducts.
And
right?
the bile ducts.
And the
the most common thing we do with that is to remove bile duct stones. So I think the important thing is, first of all, there's new methods now to thoroughly clean that. It's been recognized. I think for our viewers it's important to understand that standard upper endoscopy and colonoscopy, there is very minimal risk. And even if you have to have an ERCP, it's because you need it. And the scopes are now being thoroughly cleansed. And I think that risk at this point in time is very, very low.
All right, very good. The colonoscopy, it is the best test to find colorectal cancer early, but for doctors, it is often a hard sell to reluctant patients.
Well, we talk about the limitations of the testing, and that's something most patients want to hear from their physicians. They don't, if it's the cost of a test or if it's how sensitive or specific a test is, they want to make sure that if they're going to go through the work of the prep, that they're going to be evaluated. And then what's the appropriate screening? So we tell them their options. So you either get a stool test every year for blood, that's one method, or we do an endoscopy every 10 years in low-risk individuals, or if high-risk individuals, we do these every 5 years. And so a lot of this comes when we have our preventative maintenance visits. And I came from training in Nebraska where we learned to do flexible sigmoidoscopy, and that was the initial way we screened patients to look for colon cancer. And I remember probably within my first 6 months of practice, I had an elderly gentleman show up and for his annual exam, and I basically pleaded to him to get his screening exam done. Well, he said no. A couple months later, he came back for a checkup, and sure enough, he agreed to get it done. We did his flexible exam, and the flexible sigmoidoscope is much shorter than the complete endoscope. But we did the exam, and sure enough, we found a colon cancer. And it was really, I think, empowering to that patient to understand the value of why we did screening. He's still my patient today, 16 years later, and without that screening test, we would have not made that connection and saved that life. I have a similar story that just happened this last month. This last week, I was seeing a patient who we sent home the stool cards. It's a method to test for blood in the stool, a test for human blood. And we do that on patients who are either very ill, have advanced illnesses, and may not want to undergo the invasive procedure, the colonoscopy. And we don't do flexible sigmoidoscopies anymore. Standard of care, for the most part, is colonoscopy. And we talked about the risks and benefits, did the procedure. He also was a gentleman with advanced lung disease, and so we had to do him in a hospital setting. and worked our way through his colon, and sure enough found another lesion. So that journey for that patient begins again, and how we can hopefully give him a similar good outcome.
Thank you, Rob Allison, for that information. That was at the state medical meeting last year, and we thought I'd put it in right here, bringing the point about colorectal cancer and screening for colon by colonoscopy. Do you do a lot of colonoscopies,
Every
Cristina?
day, yeah, absolutely. And it's just so important. Age 50, get in there, do it. The worst part is truly the prep, what happens the night before. But even that is getting slightly better. There are a few newer preps that seem to be a little more tolerable for individuals. So things are getting better.
It's a heck of a lot better than colon cancer.
Yes.
My father died of colon cancer. Leaves me with a certain bad taste in my mouth with that disease, and I think it's important that we address it. Anything that you want to finish up with that, Tim, that was pointed out by Rob?
I think Rob made a very good point. There are some patients that are just going to say, look, I do not want a colonoscopy. They may have had a bad experience with a relative, what have you. I think the key point is there are other methods of screening. Dr. Allison mentioned testing the stool for blood. There's newer tests coming out now that's actually testing for DNA that can be shed by that precancerous polyp or an early cancer, and that's even more specific. If those tests are negative, you're good. If they're positive, of course, then you will need a colonoscopy, but at least you've had that initial screen that was non-invasive. So I would urge patients, get some form of screening, whether it be colonoscopy, a stool test, but something, because it's the one type of cancer we can prevent.
We can, and it can be a miserable end, so we'd like
Very
to try
much,
to avoid it. From Iowa, what recommendations do you have for a patient with diverticulitis or diverticulosis? What's the difference?
Itis means inflammation of those little pockets in the lining of the colon.
And so the pockets, why do people have them?
Well, it's genetic. Half of us have it, and probably due to really a poor fiber, low fiber diet here in the United States.
So the Africans who eat bark and rough.
Sub-Saharan Africans, we do not see this.
So, but it's also a genetic thing, I think. It's more,
Absolutely.
the more white and northern Western European, the worse it seems to happen.
I think the big point I like to make, the big myth out there that I'd like to dispel tonight, and I know you see this in your practice, Christine. For years, people have been told if they have diverticulosis, you need to avoid foods with seeds, nuts, popcorn.
Yes.
The theory was that they would get caught in these pockets and create a diverticulitis. Well, it's a myth, and we actually now have very good studies that prove that it's a myth. And I still see this where patients are, and think about it, they're avoiding foods that are good for them. You know, and for no reason. And it's funny, when I tell people that, they've been told for years, and so they're still a little uneasy. My advice to them is, if you notice a food does cause you problems, obviously then you may want to stay away. But don't avoid these foods because of the fear of diverticulitis.
Right, actually higher fiber, which is popcorn and nuts.
Exactly.
And they did a really nice study, probably about 4 or 5 years ago, that looked at over 10,000 patients. And who got diverticulitis? Overweight patients. That was the conclusion of the study. They looked very closely at diet, no correlation.
But I've seen skinny people with really bad diabetes.
Yes.
So how about if they sit on the can and they push and push? Is it popping out those things? Do you think the time, how many news weeks that they've read on the toilet might have anything to do with it? Don't know. You don't know that answer.
I would doubt it, but we don't know.
Okay. I left you with a mouth and
you did.
A gag.
I think we were both didn't know how to answer that.
So Mitchell, 62 years of age, please discuss color of stool. Does the different color of the stool mean anything or different illnesses? So what brings on different color of stool?
You know, a lot of factors determine that. And we get that question. People are scared if it looks green. Well, that simply could be because you've got a little more bile that's coloring the stool. Actually, our stool would be white.
If it weren't for
bile. The bile acids are secreted and help us absorb fat. And the remainder gets emptied into the colon, which gives it the brown, or the green,
Wow.
sometimes even a yellow stool.
So it's a bile. But blood makes it black.
Blood makes it black. If you have a black, what we call a tarry-looking stool, beware. Now, Pepto-Bismol,
That'll make it black.
that'll make it black, and iron pills can
Iron
make
pills,
it black.
yeah.
But nonetheless, if patients are seeing black, that's at least cause for concern. And obviously, if you see frank red blood, that's also
That's a
concern.
big,
Absolutely.
that's a big sign.
Correct.
Blood in the stool. Now that's not toilet paper blood from hemorrhoids. It's blood in the stool.
Correct.
Yeah.
And that's the big red flag.
Yes.
Blood in the
Absolutely.
stool.
Yes.
And I wanted, there was anything else. Oh, people with gallbladder disease will have floating feces and flatulence and yellow stool. I mean, any truth to that?
Yeah, and malabsorption, pancreatic disease, you're going to see a greasy sheen to the stool if you're having malabsorption. So yes, pay attention to your stool, look at it, that's okay.
You know, it may be poop to you, but it's bread and butter to us.
That's exactly right.
That's right. Bad joke, old joke. Caller's daughter tested positive for celiac after symptoms of constant hunger and constipation. Mother is asymptomatic, but it's also tested positive. Discuss that. Positive celiac test in a person without symptoms.
You find it, most often you'll find it in the drive-by upper endoscopy. So you're looking for reflux disease, you go, you complete your test, you look in the small bowel and say, something doesn't look right here, you biopsy. And so an asymptomatic patient will have celiac disease. In the mother's case, I bet once she becomes gluten-free, she will start to notice a few changes. Maybe she will have more regular stools, maybe she'll have a little bit more energy. So I think over time she may have some improvement or notice some change.
I think it was the Annals who had a study where they looked at all these people who they found had no symptoms but were positive because of family members, and they put them on a gluten-free diet, and they remarkably improved. They were normal, and they improved from normal.
The other interesting thing you brought up there was constipation. You know, notoriously, I think, certainly when I was in training, we always thought of sprue as diarrhea, bloating,
Sprue,
weight loss.
another name for celiac
Another name for
disease.
celiac. But we are learning now that it can manifest in a broad range. Bottom line is, if you have digestive symptoms that you just are having a hard time explaining, I think it's worth at least giving it a consideration.
Patient of mine, dear friend, who came in with iron deficiency anemia. Oh my gosh, I'm afraid he's got colon cancer. And so I did the colonoscopy and it was normal. So I had the surgeon do an EGD, and she took the normal biopsies, or he took the normal biopsies, and it came back, oh, hint that there could be the possibility of celiac disease. So I did the TTG antibody blood test. Boom, he had it. And since I put him on a celiac diet, his iron deficiency anemia went away, and he was wasting away to nothing. He gained weight. Now he weighs more than he wants to weigh, but he was wasting away. So it's an amazing story. Celiac disease presents in many different ways.
Yeah, very much.
Can attacks of diverticulitis be prevented? What foods should be avoided? So we're back to diverticulitis. Attacks of diverticulitis.
There is really no good way to prevent it, and certainly not by diet. We have learned that if you get diverticulitis at a younger age, that can portend a more aggressive approach. And certainly you want to treat the initial attacks, if at all possible, conservatively with antibiotics. But if that young individual keeps coming in with documented, and I think the key here is documented recurring diverticulitis, that's the individual you might want to consider surgery earlier.
Right.
Because what can happen is, diverticulitis is when there's a small perforation of one of these pockets, and so you get normal bacteria in the colon, leaks out into the cavity, the abdominal cavity, and that sets up an infectious process and an abscess.
And these are where diverticuli normally occur, right, in
Most
this area.
commonly in the same way, although
North
we see them
America.
In North America.
we can see them all over. But with diverticulitis, what happens is one of these little pockets can break, and bacteria will seep out, and what can happen? This sets up an inflammatory reaction. Over time, it can form a large abscess cavity, a pocket full of pus, if you will.
Wow.
That's when it gets serious, and that sometimes we try to drain it with catheters, or sometimes surgical intervention is necessary.
Right.
And what we want to do is prevent that from happening.
Because that's a big time problem.
Yes.
After having GI issues all his life, Coy Use finally got tested for celiac disease after his daughter was diagnosed with a gluten intolerance.
Interestingly, I have always had symptoms as a child. I just didn't realize it. I wasn't diagnosed until my daughter Audrey was diagnosed when she was about 2 years old. Her pediatrician noticed that she wasn't gaining enough weight, and that was actually an issue through my wife's pregnancy with Audrey as well. She wasn't gaining enough weight in the womb. So she was actually, my wife was bedridden for the last month or so of the pregnancy because of that. And then once Audrey was born, we started tracking her weight and her growth. And she was always in the very low percentile of growth for pretty much everything that they monitored. And the pediatrician's daughter had a gluten intolerance and had similar issues, and so she just suggested that we take Audrey off of gluten. And it worked. She started gaining more weight and growing. And so the pediatrician said it's usually genetic, and one of you, meaning my wife or me, is probably gluten intolerant as well. And so she suggested that we cut out gluten. And it was more likely me because I had always had digestive issues as a child and a teenager and a young adult anyway. And so I cut out all forms of gluten that I could, and I started feeling really good. I felt great, much better than I ever had in years before. And then eventually, probably in 2008 maybe, I actually had a biopsy done and was confirmed that I had celiac disease.
I'm homeschooled, so it's kind of easy, but I used to go to first grade at Hillcrest, and I brought my own lunch, but I bought the milk. I just brought my own lunch. Usually I brought a sandwich and an apple. I really like macaroni and cheese, and my daddy just made some pumpkin bread, so I like that too.
I don't have any issues now. I think probably the biggest problem for me is shampoos, body washes, conditioners, because some of those have oats or vitamin C supplements that contain gluten, and I don't think as often to check facial products or body products. And so I will, like just a few weeks ago, I used some shampoo that had some vitamin C supplement in it that was made with gluten, and I had a rash break out on my face and on my shoulders and my back.
One time I went on a sleepover with my friend Maggie, and she let me borrow some of her face soap, and my eyes got real puffy.
Hy-Vee here is great, and they will order anything that you want as well. And then most of the restaurants in town actually have gluten-free varieties of foods too. Like the biggest thing that I missed when I cut out gluten was a sandwich, just a nice sandwich. So I think it's really just finding somebody that has been living with it and just has gone through the trial and error, unfortunately, of trying to figure it out. And then obviously talking to a doctor. I mean, I think I never really consulted with a doctor other than having the biopsy done, and then obviously getting an informational sheet about this is what, the traditional things you need to avoid. But for me, it was just trial and error. You kind of figure out which products work for you and which ones don't.
We thank you for your questions and a very interesting story about celiac disease. Cristina, so if I thought I had celiac disease and I went on a celiac diet and then I wanted confirmation, how does that work?
That makes it tough. So it's a big challenge. So don't do what the magazines, your women's magazine or whatever will tell you. So please remain on gluten until you see us, and we'll do a blood test. A primary care doctor can do the blood test. Because if we really want to know if you have celiac, you have to be on gluten. Otherwise, it can be a false negative test.
In other words, if I go on a gluten-free diet, the problem goes away, and the blood test normalizes?
Yeah, exactly. The blood test can normalize, the biopsies can normalize. They'll say, well, we'll never know. And by that time, the patient is feeling so good. He or she will say, well, I don't want to go back on gluten again, and they don't want to risk it. So if you have an inkling that it could be celiac, come in right away.
Just get the blood test anyway.
Absolutely.
Right?
I think the other point is, this is not an easy diet. And to commit yourself to lifelong gluten-free without the disorder can be tough.
But maybe if I do a little bit of a gluten-free diet, what do you think of that?
I think that obviously that's not good, because I always tell patients, if you just smell, if you just sniff gluten, that's enough to set off this intestinal reaction.
I mean, what is the cause of the reaction? I mean, is it an immune system problem?
Right, it's a protein actually in wheat, barley, and rye that causes an immune reaction in the small bowel, and that causes the nice finger-like projections of the villi of the small bowel to become kind of a tile floor where nutrients
so it goes
cannot
from
be...
a shag carpet to a tile floor.
Tile floor, that's what I tell my patients, and you cannot absorb.
Nothing.
Malabsorption, you lose nutrients, and all sorts of long-term bad things can happen. So good to make the diagnosis. Get the blood test anyway.
Simple.
It's not a very expensive test.
No.
Good point. Here is a 40-year-old in Sioux Falls, severe abdominal pain. The doctor says she has a sluggish gallbladder with sludge. Docs say it's still functioning normally. Do the doctors on the show have any idea what's causing the pain? And my comment is, it's hard sometimes to make that diagnosis of gallbladder disease. We miss it, don't we? When it's really gallbladder disease.
We really do. You know, I think both Dr. Hill-Jensen and myself, we see sometimes where gallbladders are taken out and the symptoms are still there. In other words, that didn't cause the diagnosis. I personally sometimes get so wrapped up in trying to make certain that if we're going to recommend surgery, that it's absolutely indicated. You know what? Every now and then, we miss it.
Right.
The gallbladder is a difficult organ, and the key is communication. It's communication between the patient and the provider, listening to each other, carefully discerning these symptoms, and trying to make the best decision possible.
I had a patient who had gallbladder symptoms. I said, this is it, ultrasound the gallbladder, normal. Came back, you know, still, this is gallbladder disease by story. I mean, this is perfect gallbladder disease, gallbladder function test, normal.
Yep.
And I finally said, you know, I'm going to have the surgeon a shot. And the surgeon says, this is gallbladder disease. I'm scheduling your surgery tomorrow, you know. Surgery gone, gallbladder problem went away.
You know, Rick, that was classic teaching even in the fellowship. The best predictor of is that patient going to do well after gallbladder surgery? Do they have classic symptoms? The key is understanding what the classic symptoms are.
What are the classic symptoms, Cristina?
Pain, starting midline after eating, moving over to the right side, and is associated with food.
Okay.
Nausea can be accompanying it as well.
All right, that's good enough.
But nausea alone?
No.
And abdominal pain, there's a lot of things that cause abdominal pain. How do you evaluate abdominal? Do you go right to the CAT scan? People come in with gallbladder, or I mean, sorry, abdominal pain?
Well, by the time they see us, they've usually had a CAT scan.
Yeah.
And, you know, and the point about the CAT scans, they're very good, but remember, this is radiation that we are
100 chest
giving
x-rays.
to patients.
Yes.
And so you have to be, and there's nothing that replaces, I'm going to sound old school here, but there's nothing that replaces a very good history and physical examination. We have all these wonderful technologic tests, but it's the doctor listening carefully to the patient, telling them their symptoms. That is the best way to make diagnosis.
Absolutely.
Did you hear that? Say that again. The history and the exam and the doctor taking some time, and listening.
It's huge.
Huge. Caller wants to know if bile is affected when most of her ileum has been removed, and says hello to Dr. Ridgway.
Oh, I love it. Well, hello to you. The answer is yes. Most of the bile that is secreted from our gallbladder and goes into the small intestine, it helps to absorb mainly fat and our fat-soluble vitamins. But then the majority of it is absorbed back in the terminal ileum, which is the last part
of the small intestine before it dumps into the
it dumps into the colon. And so one of the things we see commonly if people have had removal of part of that last portion of the small intestine, the ileum we call it, which comes right off, right like you're showing there, Rick, if that's been removed for a variety of reasons, what happens is more bile gets dumped into the large intestine. And that's literally like taking X-Lax. It stimulates water secretion into the colon, and guess what? Diarrhea.
So, I mean, I have a ton of people who have had their gallbladder out and have that biliary colic history. But that you're saying that this part is also
absolutely
extremely important.
Absolutely. And the other thing we will see, there's a certain vitamin that's absorbed in that area, vitamin B12.
Very good.
And so if they've had enough of that small intestine removed, you better have a B12 level checked to be certain.
Well, I think people particularly with any neurologic symptom, any numbness, any tingling, should always have their B12 tested.
It's cheap and it's easy to replace.
Is there anything that you'd like to add to what he said? Biliary colic, you treat it very easily though, right? With Questran.
Yeah, yes. So with the diarrhea associated with the gallbladder being out, Questran works very well, absorbs everything. Be cautious with it because it can absorb your medication.
Exactly.
So
And
you
your
have to
B12
time
as
it, and yes, exactly.
Yep,
That's
very
the
good.
toughest part about it. You have to make sure
Timing.
they take it away from their other medicines.
So, quick one. How much effect does the brain have on the intestinal tract?
Well,
That's not a quick answer. Yeah, no.
it's not a quick answer.
Well,
No, I mean, there's whole centers for neurogastroenterology. So the brain has a huge effect on the GI tract, starting with meals. The brain sends signals. I mean, it's huge. Yeah.
there's a new drug out for people who have irritable bowel syndrome. We're going to talk about that when we come back about irritable bowel. Are you prescribing a lot of it, and what is it, and how does it work? It's related to the brain, or am I wrong?
Which one?
I'm blocking on the new irritable bowel drug.
Linaclotide?
Yeah.
No, that's not brain necessarily. That's still colon.
Okay, it's colon.
But the point is, we've known for many years that certain medications that have brain function, a common antidepressant only in doses that's not antidepressant at all, it's called nortriptyline or amitriptyline, certain amount of patients with irritable bowel syndrome
Get better with that.
get better. And the interesting thing too is that when we look at all these treatments for irritable bowel syndrome, one of the things that works the best, periodic visits and the physician being supportive and listening and just not telling the patient, it's all in your head, get out of here.
Because it's not, but they struggle, and there's not much we
So
can do.
it's like Cristina said, there is we think there is a huge connection between the brain and the gut, and we've just touched the surface in terms of how much.
One last
it has.
thought about Crohn's disease. Crohn's disease has nothing to do with neurologic. It is an inflammatory disease of the small and large, anywhere from the lips to the anus.
Literally, yes.
Any quick explanation for Crohn's disease? What is it, Christine?
So it's another autoimmune disease affecting 500,000 people, men and women in this country, causing deep ulceration in the lining of the GI tract. I say it's like you get potholes, and these potholes, one type of Crohn's, can bleed, cause pain, discomfort. But there's other types of Crohn's disease causing fistulas, abnormal connections between organs, drainage of stool from places other than the rectum, and narrowing, scarring of the small bowel as well.
It's a really tough disease.
It's a tough one, and we're getting closer and closer to the etiology. It is an immune disease, and the bottom line, if you want to simplify it, the bowel is an incredible immune organ. And with these inflammatory diseases, we think that the pro-inflammatory, we call them cytokines or proteins, they outweigh the protective ones. So the bottom line is there's an imbalance. And when you get more pro-inflammatory proteins, they attack the bowel lining, and that leads to the symptoms that she was talking about.
Well, Danita Fisher started having severe GI issues 7 years ago. After a Crohn's disease diagnosis, her life has never been the same.
First it was Crohn's, then irritable bowel syndrome, hypoglycemic gastroparesis, chronic inflammation of the stomach. It took my job away from me. The illness did. I'm on disability. I can no longer work full time. I have to rest. I get tired out very easily. My blood sugar, I have to be very careful with my blood sugar, what I do. Just cleaning the house at home, I get sick. And if I eat, I get sick and have the pain. If I go for like 2-3 days without eating, then there's no vomiting, there's no pain, but then my blood sugar drops, so then by day 4 I have to eat, and then it starts all over again. Find someone to talk to, go online, find support groups, find a good specialist that deals with it, friends, family, church, because I dealt with, I'm a Christian, but I'm not the church goer, but you question your faith, you get mad at God, you know, you need someone to talk to, not necessarily to give you any answers. You don't want, I've never wanted sympathy. I just want someone to listen and let me yell, scream, cry, because it's all life-changing and it completely it's hard to not let it run your life, but it does. It does.
That looks like a very tough disease. I mean, I saw that she appeared very emotionally drained from the whole thing. What do you do for your Crohn's patients who are so wiped out by it?
You know, I feel that as a gastroenterologist, I in some ways become their primary care physician, because this is a debilitating disease. Who wants to go out and explain their diarrhea, their pain, their weight loss? It's a very emotional thing. And so what I always try to do is get them to support groups. And it's amazing what happens when you get a group of people in the room that have the same struggles. And that is as therapeutic, frankly, I think, as any drugs that we can give to try to control this. Yeah. We have medications that we're getting better, and they basically work along the immunologic line to try to get that balance back in sync. But we can't cure this disease. Wow. It's a chronic disease.
It's a disease that we have to live with and support these people who have it.
Very much need support. I thought that individual said it best when she said, I just need sometimes somebody to listen to me cry, scream, or whatever, and understand. And understand.
Right. Very good. There's been an epidemic of salmonella that presents itself sometimes with very bad diarrhea. Tell me a little bit about salmonella, Cristina.
Well, in the worst form, you can see bloody diarrhea, and it can be associated, you think of eggs, chicken, huge outbreaks, different parts of the country. And I don't know where the latest one is now, but it seems to be every year there's an outbreak of either salmonella or listeria. Things can go around like that.
And those are kind of similar, aren't they? Listeria is a bacteria. Listeria monocytogenes is the one that comes with kids. The babies in particular, with their immune system so down.
I think there's one outbreak now in hummus. They're recalling that, some ice cream with listeria, so yeah.
Soft tissue. I've heard that the salmonella is in the kids coming back from spring break. Ah. So, you know, of course we love spring break, but there's some problems that can occur. We've got some graphics apparently that we can look at here. How do you prevent it? You want to cook the poultry and the eggs properly. You don't.
Diagnosis, it's reportable to the state health department, because we want to control and contain these outbreaks.
Right. Very good. Well, how does we have a bunch of questions? How dangerous is an umbilical hernia?
Well, it can be if it's large enough to incarcerate some small bowel. So small bowel is getting stuck in that area. You're not able to push that little area back in. It can be an issue.
You're in trouble. Yes. Starts to hurt you.
If it gets caught, it gets inflamed, and you're in trouble.
Right.
Small ones, usually asymptomatic, and they do okay.
Do we see diarrhea? Is there a spate of diarrhea illness in the area right now? Are we seeing it, or are you seeing like what I see, which is a little bit here, a little bit there? It seems to run, no pun intended, periodically, but it seems to be there all the time. I see an infectious diarrhea that comes and goes all the time. Am I wrong?
No, and that's the key. You know, the commonest cause of diarrhea in this country, interestingly enough, is irritable bowel syndrome. But having said that, the key is if you're walking along doing fine and have never really had much diarrhea, and all of a sudden you get a sudden onset that lasts longer than a couple days, that's concerning for an infectious problem, and you better get in and get tested.
All right. 35-year-old Mason, South Dakota, is a person old to get fistula tract repaired. So someone has a fistula tract, is a person able to get a fistula tract repaired? Fistula tract. Tell me about a fistula tract. I'm thinking Crohn's disease, anal fistulas, but what else?
That's mainly it. Anal fistulas that can occur without Crohn's disease, or with Crohn's disease, we see them commonly as well. And the issue there is how symptomatic is this fistula? If it's, a fistula, what is it? It's an abnormal communication. It's a communication from one organ, usually to another organ or to the skin. And you drain fluid from the gut out this tract. And it's commonly seen down in the anal area.
So this is the colon, and then this is your buttocks.
Correct.
Okay. So where is the fistula?
The fistulas usually will start in this low rectal area, and then they can drain. So commonly, you might see drainage out a little tiny tract in this perianal region. And it can be repaired if they become symptomatic enough, and surgeons will do this. They're very skilled at it. And basically, sometimes they can just open this up and create a bigger drain to allow everything to heal inside. And so are you ever too old? I'm not sure you are, because it doesn't require a major operation. I think the key is seeing somebody who's very skilled and knows when to do something,
right,
but more importantly, when not to.
All right. Anything to add?
With Crohn's disease, it can be a major issue as well, which sometimes not only with extra drainage will require some heavy-duty medication to heal that up. So then please seek a GI's input.
And I do want to point out, with Crohn's disease, you want to avoid surgery down there.
Yes.
That is really an important point, because
Absolutely.
it can make it worse. In the simple fistulas, surgical repair, excellent, but with Crohn's disease medication, you want to be very careful.
Medication.
Yeah.
Wow. 78, we're going to run through questions. Quick answers.
Fire away.
Here's Sharon. Caller's stomach becomes distressed when she goes to sleep, feels the need to eat. What causes this nighttime stomach distress? Christina.
You could think of peptic ulcer disease. Are they having reflux type symptoms when they're
when they lay down?
Yeah, absolutely. So those would be a few to.
Right. And maybe they're eating ice cream after supper.
That could be, and then try not to eat right before bedtime, 3 hours.
Yeah, they say you should eat breakfast like a king, lunch
Absolutely.
like a prince, and supper like a pauper, and nothing afterwards if you're having gut problems. What are the different symptoms of IBS versus a bacterial overgrowth in the gut, and what are the remedies? So let's talk about IBS and then do bacterial overgrowth.
IBS.
Irritable bowel syndrome.
Irritable bowel syndrome, what is it? Well, it's the commonest cause of GI symptoms that we see in a gastroenterologist's office. There is a multitude of etiologies. We're still trying to determine one specific etiology. We think that there's a gut-brain interaction. We think that motility has a big deal. Motility means the motor function of the gut. That can be disordered in irritable bowel syndrome. It can manifest in many different ways. Bloating can occur. As Dr. Hill-Jensen said, up to 40% of the population has bloating. It can be a change in bowel habit. One day you will have diarrhea, the next day you'll have constipation. Usually is relieved, symptoms can be relieved with a bowel movement.
So we've got meds for constipation.
Sure,
irritable
so
bowel.
you can have constipation predominant, you can have diarrhea, or mixed, like what Dr. Ridgway was saying. And so you try to treat those symptoms. So treat spasm, treat the underlying constipation, treat the diarrhea.
Okay, I like high fiber. I like ground flaxseed.
Yes.
And avoid milk. And a little bit of amitriptyline.
I had a nurse for years that swore on flaxseed, and she sold me on flaxseed, and
I've had my flaxseed today.
Absolutely.
80-year-old caller had colonoscopy, one polyp removed, which caused bleeding. A week later, discuss the criteria for getting a next colonoscopy.
Well, hopefully age 80, no more.
At 80,
yeah,
no more colonoscopy?
Well, so guidelines are really kind of variable, but 75 to 80, you need to have a talk with your physician as to, and sometimes these are tough talks, but do we need to continue to do preventive type screening in these individuals? Right. So maybe no more colonoscopy.
But if there was a polyp, then you should probably follow up.
Probably follow up and talk about that, but you start talking about life expectancy. These are tough things.
The risk of colon cancer versus the risk of the procedure itself. Now, I want to reassure this person that wrote in, bleeding can occur. We remove a polyp. If we use cautery, it forms a scab, an eschar, if you will. And when that sloughs off, just like if we scrape our arm, if it sloughs off a little early, bleeding can occur. To no fault of the colonoscopist, it's a known risk. It doesn't happen often, thank goodness.
It's generally not a big deal.
Usually not. Every now and then we have to go back in and do it, and rarely would surgery be necessary.
Someone is overweight, very little abdominal muscles due to abdominal surgeries. Is there anything that can be done to support the abdomen because it's uncomfortable? And you know that. There's these people who've had surgery and they have this large kind of abdominal hernia that isn't dangerous, it's just uncomfortable. Nothing?
Not really a support, not that I know.
No, short of abdominal support wraps that I'll recommend to try to help them get in, but it's very difficult. That's a tough problem.
I had a patient who had this kind of surgery at the Mayo, and they took muscles and they wrapped the muscles around. I mean, it was a very extensive surgery. It was very post-operatively painful. But the hernia hasn't reoccurred. There was some muscles that came back, but it's one more problem associated with overweight, and it's kind of hard to help them when they're pretty heavy.
You know, one thing, Rick, I wanted to get back to that person that asked about bacterial overgrowth. The symptoms are exactly the same as irritable bowel syndrome, and the key is for the doctor to think about it because it can be treatable.
Well, and of course, one more reason not to go with antibiotics. Avoid antibiotics if you can, because what it does is it brings on bacterial overgrowth of the colon. What about probiotics? Do you prescribe them?
Well, they're over the counter, but yes, we definitely talk about them. I tell patients it's a 50-50 shot. It has a role, I think, in some individuals, those who have small intestinal bacterial overgrowth, you treat, and then you put them on a probiotic. Patients who have ulcerative proctitis, I think we're still looking at it with other diseases like Crohn's disease, but it doesn't hurt. I will say, though, no offense to Jamie Lee Curtis, but you cannot eat enough Activia to get,
Beware the marketing, beware the yogurt. The amount of probiotics that you're getting is so minuscule.
You have to eat 6 to equal what you get in one pill.
So, and the BioGia, is that the one that you like the most, or is there one particular probiotic that you like?
For my patients who say have had recurrent C. diff infections, I use VSL number 3, so it has 3 different strains within that.
What is it called again?
VSL number 3.
How's that?
Okay, it's VSL number 3. What's the age limit that a colonoscopy should no longer do? We know that 80 for screening, but not if there's a problem. How often should children have colonoscopies? Ages 45, 50, and 51. That's her children.
Her children are 45,
Dad and Grandma
50.
had colon cancer. Mom has celiac disease. Should her 45-year-old, 50, and 51, Dad and Grandma had cancer?
I think the issue is at what age was the dad diagnosed with colon cancer? And this is something that we're learning more about. If you've been diagnosed, a relative under the age of 60, that is risk, but if it's over the age of 60, we know that risk isn't that high.
All right, good. We'll be back right after this.
Quit smoking, and in just 20 minutes, your blood pressure returns to normal. In 12 hours, carbon monoxide levels in your blood drop. In 48 hours, your sense of smell and taste improve. Within 2 weeks, your lungs work better, you heal faster. 9 months means more energy, fewer illnesses. And in 5 years, your risk of heart attack is half of what it is now. Take a deep breath. You can do this.
A 20-something gentleman presented to the walk-in clinic a few years ago with severe diarrhea. He was working at a feedlot where he was exposed to cattle and all their byproducts, and he admitted that his hand-washing skills were not ideal. He'd been ill for a few days, was getting dehydrated, and now there was blood in the stool, more than you'd expect from just hemorrhoids. An estimated 2 to 5 billion episodes of diarrheal illness occur every year worldwide, mostly from infection in infants. In 2013, more than 1.25 million people, mostly babies, died from dehydration due to diarrhea, mostly the consequence of contaminated water. It's in the amazing small intestine and colon where roughly 2 gallons of fluid flow through daily, only to be reduced to about half a cup of fluid that exits in the stool. That is, unless something goes wrong. The word diarrhea literally means through flow. The electrolyte explanation for what causes diarrhea runs on like a chemistry teacher on too much caffeine. But suffice it to say that we are still learning the complexities of such a system that, when working correctly, turns the stuff we shove into our mouths into micronutrients and water, and then carries the necessary parts of this slurry into the bloodstream in order to keep us alive and working. Non-infectious causes of diarrhea include problems like shortened bowel, partial blockages, immune problems like Crohn's disease and ulcerative colitis, and intolerance to certain foods like milk products and the gluten in grain. The diagnosis for infectious diarrhea is made primarily from the patient's history or story. Clues for the cause can include previously attending a daycare or anywhere diarrhea illness is present, working where there is exposure to animals, eating undercooked or spoiled food, and traveling to another country south of the border. Antibiotics are rarely needed to treat infectious diarrhea, and in contrast, life-threatening diarrhea can result from an exposure to antibiotics. The most challenging cause for diarrhea comes when a person is burdened with a very nervous and sensitive bowel called irritable bowel syndrome, or IBS. This diagnosis is made when everything else is ruled out. A professional should evaluate any diarrhea lasting longer than a week or produces internal bleeding. I admitted my patient to the hospital for IV fluid hydration. The diarrhea resolved spontaneously without antibiotics, and he vowed to do better with washing his hands. This brings us to the end of our show this evening. I sincerely thank our fantastic guests tonight, Cristina Hill-Jensen and Tim Ridgway. Thank you, Cristina and Tim. Our friends at the South Dakota Helpline Center are hosting a 5K run walk at the SDSU campus in Brookings this Saturday, April 11th, to raise funds and awareness of suicide prevention. For more information or register, go to helplinecenter.org. As early 20th century American politician Frank Clark noted, a child like your stomach doesn't need all you can afford to give it. And until next time, from all of us here at On Call with the Prairie Doc, stay healthy out there, people.
Merriam-Webster defines geriatrics as a branch of medicine that deals with the problems and diseases of old age. But when does that time begin? Is it the same for all of us? How do we prepare for those problems? Geriatrics, next time on Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera Brookings Health System, and Fishback Financial Corporation.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. We had a bunch of questions. We want all of them answered if we can. Your questions are important. We want to answer as many. So here we go. Is esophageal cancer hereditary?
The answer is likely not. We don't have a strong familial predisposition. Usually acid reflux can be a substantial risk factor in certain individuals. Smoking is the other one. Family history, not as important.
Not as important, although I have a Chinese patient who saw me today, and his mother and father both had esophageal
and that's
cancer.
not to be taken lightly, but I don't think it's near as common like, for example, breast or colon cancer.
Right.
Agree.
Green tea, would you, if you had esophageal cancer in your family, would you drink green tea?
I would promote a diet and a lot of antioxidants, so fresh fruits and vegetables. Green tea probably won't hurt.
No.
Mm-hmm.
What can we do about esophageal reflux? How do we prevent reflux esophagitis?
Weight is a big one, and how you eat. So it's lifestyle modifications. If you don't want to take a pill, modify your diet and watch your weight.
It's the harder thing to do, but it's the best thing to do.
Elevate the head of the bed,
Right.
because a lot of it's
don't eat for 3 to 4 hours before bedtime and laying down. And overweight is really the significant. High fatty foods.
Yes.
Right. Okay. Are there any dangerous severe side effects of omeprazole or Prilosec? Also, can reflux initiate an asthma attack? Good questions. Prilosec, is it, people are on it for years and years and years. Is there side effect?
Yes, there are. I mean, we're learning osteoporosis, for example, thinning of the bones. There's been some reports that it might promote an intestinal infection called C. difficile. So it still, I think, by and large, when used judiciously, is a relatively benign drug, but we cannot be lulled into a sense of security. There are side effects that we're seeing when used long term.
And can you see asthma? Yes. If you have reflux coming up, just spraying, it's like a nozzle spraying your vocal cords, yes, acid can contribute to reflux and cough.
So people get cough and asthma from the reflux.
Yes.
Right. Are there any dangerous severe, are there risks to colonoscopy? We've talked about that.
Yes.
Constant cough with reflux, what kind of testing can you do, should you do, and
well, I think one of the easiest is try a proton pump inhibitor, a medication like Prilosec, and then we move into looking, is this truly acid related or not? And so you can actually test acid levels, do a pH study, be it through a tube down your nose for 24 hours, or we clip a sensor into the lining of the esophagus, measuring acid, and then we correlate that with symptoms.
so you give that to people who really fail everything else?
Exactly.
Okay.
But a good trial of high-dose proton pump inhibitors like Prilosec is a good
Prilosec
first
or
start.
Protonics, do you prefer any particular brand?
No.
You know, your omeprazole is generic and it's cheaper.
Whatever's cheapest.
Okay, stool softener every day has been, has a movement every day, still very doesn't have a bowel movement every day though, still very constipated, taking tramadol for pain. Could this affect constipation?
Absolutely.
So tramadol can cause a constipation.
Yeah, absolutely.
Stool softener is a good choice, though, don't you think?
Right. So what is normal? 3 bowel movements per day to 3 per week. But it's more so feeling as though you empty out completely and you don't have to sit and strain and spend a lot of time in the bathroom. So
three a day to 3 a week.
Yeah,
yep,
you do
that's
not
normal.
have to have a bowel movement
Not
every
like
day.
what Dr. Oz says, yeah? So
If the patient is otherwise is doing well, not to worry.
I tell people to avoid stimulant laxatives. I think osmotic laxatives like stool softener, milk of magnesia.
Absolutely.
I prefer Miralax.
Miralax is
the
a
best.
wonderful addition to our.
It's been a good thing, hasn't it?
Yeah, very
How
safe.
about the new kind of expensive drugs?
They're expensive, and the bottom line is, in the majority of patients, you don't need it. Despite what the marketing says, you don't need it. We've got very good alternatives.
There's sometimes, though, you do need it.
Absolutely, in that
it works.
Yeah, but the key point is not to jump to that as your initial drug.
What will irritable bowel syndrome go away on its own?
half of people with proper treatment in 1 year will have no more symptoms.
And proper treatment is?
Diet and sometimes medications.
The diet is no milk,
We have,
high fiber.
and there's a FODMAPs diet, a low fermentable food item diet, so a list of foods to avoid, certain grains, certain milk products, certain fruits and vegetables, the cauliflower, the broccoli.
So you look it up where?
FODMAPs, Google it.
Yeah.
FODMAPS, FODMAPs.
FODMAP.
FODMAP. 84-year-old has diverticulitis. Do you not need a colonoscopy after some age? She's 84.
That's a good question because we see this all the time. Somebody's had an attack of diverticulitis. Why would you consider a colonoscopy? The real reason to do that is you want to rule out that uncommon cause of colon cancer. So if this patient has had a screening colonoscopy in the last 4 to 5 years, I would make the argument and say no.
Yeah.
And you don't want to go in there too soon because you could create a bigger problem.
Right. Well, it's a dangerous area with all those diverticulitis.
You're putting air in and so forth.
How important is the IgG test if it's 530? Is that a risk to your immune system? IgG, 530 IgG test. Maybe it's the TTG antibody.
Either that or they're just talking about a random IgG test for immunoglobulins, which is very nonspecific.
Right.
Something non-Hodgkin's lymphoma, Rituxan treatment, IgG test for 87-year-old. What can an 87-year-old woman do about her constant gas? Do you think that some people really do have more gas?
Yes, absolutely. Okay. But diet, so starting with a FODMAPs diet, watch what you're eating, making sure you are emptying out completely as well, so you're not constipated. I think those are basics.
And then air swallowers. Some people swallow air if you can get them to catch themselves.
Yeah, constantly, so that's behavior change.
Although I did hear one study that showed that girls pass as much gas as guys did, and I tell you, it was a surprise to me. Bad joke. Here is a story. Please talk about lymphocytic colitis.
Yeah, lymphocytic colitis, another term is microscopic colitis. And this is a situation where patients will come in and have watery diarrhea, and you've tested them upside down and sideways for different infections. Everything's normal. You do a colonoscopy, it looks normal. The colon looks normal, but you get biopsies. And when you look at those biopsies under the microscope, you can see one of two things: an increased amount of lymphocytes in the subepithelial layer microscopically, and that can cause a watery diarrhea. The other thing you might see is a layer of collagen, a fibrous substance band underneath the subepithelial layer. Both of those, interestingly, are treatable. We start first with standard treatments of fiber, perhaps an antiperistolic such as Imodium, but if all that fails, we have an excellent drug that budesonide, which is a steroid-like medication, but you don't get the steroid side effects, and it can be very effective in controlling and treating the diarrhea.
And lymphocytic colitis is associated with celiac
yes,
disease,
thank
so
you. Very
think
good,
about
Christine.
celiac as well.
Yes, think of celiac when you see it.
How about eosinophilic esophagitis, very quickly?
It seems to be everywhere. So a young man who says, I eat and the food gets stuck, these are the individuals to think about it in. So allergic type reaction of the esophagus, sometimes associated with certain food items. Start with treatment. It's a biopsy. You look underneath the microscope for these eosinophils. You would start with standard treatment of a Prilosec, omeprazole, but sometimes a topical type medication can help clear up this extra inflammation.
Your inhaler.
Exactly.
And the key is the doctor has to think about it. If they're having trouble swallowing and you don't see a stricture, you have to think of that diagnosis.
All right. What are the chances hiatal hernia occur again? First one was about 10 years ago.
And obviously had it surgically repaired. Is that
well? I don't know.
Because I will tell you, we've seen with surgical repairs, a lot of them will slip. And you can have recurrent hernias within 5 years, up to 50%.
So they end up eventually on omeprazole anyway.
In 10 years, half will be back on.
Right.
Right. And but do you repair them? Do you believe in the repair?
Challenging surgery, and you really have to convince the patient.
Careful patient selection is key.
All right. Sioux City, Iowa. Caller has lifelong constipation till a year ago, suddenly has loose bowels movement, no history of cancer in the family. It's a serious symptom. I'd say colonoscopy.
Yeah.
A dramatic change in bowel habit like that, have it evaluated.
A warning sign.
And it could be one of those things we've discussed earlier,
Correct.
too. A lot of reasons. Does using a stool softener every day have a bad effect on my colon?
No.
No.
No problem with stool softener.
None.
I sent one person, I couldn't get them fixed and they were worried, and I sent them to the Mayo Clinic. I think this is where they wanted to go. And they came back on 3 stool softeners twice a day, solved the problem.
Yep.
I think if you give them flaxseed and 3 stool softeners twice a day, a rock would have a bowel movement. Hello from South Dakota Senator, likes the show, watch, enjoying in oil field related, doing great. Watched. So, thanks so much. Is there any benefit to using detox diet that's popular in magazines and online? Detox diet. Do you have any idea what a detox diet is?
No, I would assume it's some type of elimination diet, taking out sugars, taking out wheat, but probably no major benefit. A lot of people have certain food intolerances. It probably won't hurt.
One has to be careful. There's a lot of marketing out there, and just one has to be careful.
There's
Run it by your provider
Right.
if you have a question.
So your diet for irritable bowel syndrome is again what?
FODMAP.
Great word. Word of the night, Rick. Word of the night. FODMAP.
Yeah.
Ongoing problems, belching, diarrhea, mostly smelling worse at night. What is the cause of this smelly, bad, odorous?
Whenever I hear of foul, smelling, bad, I mean, obviously it all can be not good smelling. But if it's excessively foul, you want to think about malabsorption. When we do not absorb our fat, it can be a very foul smelling stool, and you got to consider that.
Well, what causes fatty malabsorption?
There's 2 major
Celiac?
things. We talked about celiac in any condition of the small bowel, but the other one is pancreatic disease, where the pancreas becomes insufficient. And if the pancreas can't produce an enzyme called lipase, you will not absorb fat well, and the fats will cause that greasy looking bowel movement, and it will be extraordinarily foul smelling.
Would you do an ERCP, or would you do a CAT scan?
You can you can start with a simple stool test to see if there's excess fat in there. If that's the case, then the first step is to do a good CT or an MRI without the radiation, because you can see calcification of the pancreas, which is an indicator of possible chronic inflammation.
But I know of no lab person who likes to do stool for fat.
Well, and especially if you get a 3-day study for fat.
Those
They don't like that
Those are the
either.
bad ones, and I can never imagine those people doing those tests. But now we have other tests where you don't have to quite do that. You can do just a spot stool test for what we call qualitative fat to get, or there's other ones where you can check certain enzymes that are leaked into the stool. So better.
Caller wonders if she can become immune to the effects of Zantac, Prilosec, and also uses one for a while and then switches back and forth. Not that exciting. What about using H2 blockers? Things like
Well, they're definitely so your Pepcid, your Zantac, your
Pepcid,
cimetidine, so they're making a comeback, especially in the hospital setting where we want to avoid that C. diff, the hospitalized diarrheal infection.
And it's a faster
Yes,
acting.
it works quickly, perhaps not as many side effects. If it works for you for that intermittent heartburn, sure.
Go for it.
I like as needed H2 blockers like Pepcid, and they're cheap, over the counter.
And they're safe.
Yeah. get the generic version, not the Pepcid.
Absolutely.
Correct.
Not the
Much
Zantac,
cheaper,
get the
and they work
Ranitid.
exactly the same.
Please talk about SIBO, small intestinal bacterial overgrowth in Canada. What are the symptoms and how can they be tested or treated?
Well,
That small intestinal bacterial
small
overgrowth.
intestinal bacterial overgrowth. Basically what that is an overgrowth of our normal bacteria of the small bowel. Risk factors for that: if you have a slow-moving small bowel, if you've had intestinal surgery of some type, that bowel will not move as well. It allows for overgrowth of bacteria. Classic symptoms: excessive bloating and diarrhea. Treatment is antibiotics. But again, as you mentioned on the show earlier, you don't just want to randomly throw antibiotics at this. We can actually do a breath test to see if there's too much bacteria in the small bowel. You can go down with an endoscope and aspirate fluid from the small bowel and have it cultured to see if there's bacteria in there.
Latest treatment for biliary cirrhosis.
Primary biliary cirrhosis. You know, the standard treatment for years has been ursodeoxycholic acid. I recently saw a study that looks promising. Mayo Clinic is one of the world experts in primary biliary cirrhosis, where they're looking at a second new medication in conjunction with urso, and those patients did better.
So urso and?
I cannot remember the name of the medication. It's an experimental one. It's not reached prime time yet, but
Okay.
the investigation looks promising.
Wow. I've been on GERD medicine for 15 years. Can you discuss protocol to get off of GERD? So people get stuck on it. Sometimes they're on omeprazole, or even if they're on the H2 blockers, right? They had heartburn, it made them better. GERD is gastroesophageal reflux disease, so it's reflux esophagitis. There's some data to say that even if you didn't need it in the first place, if you stop it abruptly, you can have rebound hyperacidity.
Yep, so you just have to somewhat taper yourself off of that medication and be prepared for that, and know that during the first 1 to 2 weeks when you're coming off that medication, you might have to use a few more Tums here and there, but try to wean yourself off of that medicine.
All right. Caller has gastroparesis, has had symptoms of gallbladder attack several times in the past. Is delay of symptoms secondary to gastroparesis?
Well, gastroparesis basically is a delay of the ability of the stomach to empty properly. And the key there is sorting out, okay, so you do a study that suggests that the stomach is emptying slower than usual. The question is that the cause of the symptoms? And that can mimic gallbladder symptoms to some degree. And the problem with gastroparesis is we don't have a lot of good, effective medications. Reglan or metoclopramide was the classic, but that drug is dangerous, particularly in older individuals. And you want to use it very sparingly, very quickly.
Hurt themselves.
Absolutely.
I've had internal rectal pain with chronic constipation for months. I thought I could have hemorrhoids, so I tried over-the-counter medicines. After no alleviation of symptoms, I went to my primary care doctor, didn't find any hemorrhoids. It was suggested I have a CT scan, but that seems like overkill. The physician's rationale was to rule out abscess. Any thoughts?
If the pain is with defecation, the other thing this could be is called an anal fissure. And that's the common thing that I see that's missed. Because you really have to inspect that perianal area carefully. If you're having constipation, you pass a larger hard stool, it causes a tear, a rip, and it hurts badly. And that is very treatable condition. So, you know, a CT may be overkill. If there's no fever, no white count, I would at first say let's get a very good perianal examination before you jump to the next step.
Do you use nitroglycerin for anal fissures?
Sure, that and Diltiazem 2% as well.
Topical, but those are kind of spendy. You can
Yes,
get
they
them
are.
at the, you can have them made.
You can have them compounded cheaper than
compound
Yeah,
pharmacy.
and use that, and then in combination with Miralax to keep those stools
keep the
soft.
stools
And
soft.
it's and what the nitroglycerin does is it relaxes that anal sphincter so
So
that
it
it's
doesn't go
not so
spasm.
tight. Yeah.
Yep.
Is it safe to have a colonoscopy when a person has diverticulitis? She has a history of intestinal abscesses. One doctor said she shouldn't have another colonoscopy.
I would be careful. You certainly don't want to do a colonoscopy around the time of the attack of acute diverticulitis because that bowel wall is very tenuous. If you go in there, put air in there, you could put another hole in the
Blow
colon.
it out.
Absolutely.
Caller has chronic diarrhea, doesn't have celiac disease, has tried diet elimination without success. What can she do to decrease diarrhea?
This may be a diarrhea predominant irritable bowel syndrome, which we talked about earlier. Bile acid binders, such as Questran, is one thought. I've had success with that in patients with chronic diarrhea.
Absolutely.
And don't underestimate the importance of scheduled Imodium. That can be very beneficial in these patients. The problem is they'll take it as read, as needed. I'll put them on it maybe twice a day or 3 times a day. It's amazing how many times that'll work.
Before you go out to church, before
Yes,
you go out
exactly. When you're going to drive and you don't want to have to stop at the restaurant. Yeah.
Because it's safe to take.
75-year-old prepped for colonoscopy, unable to proceed, secondary to incomplete emptying. Now getting ready for her second colonoscopy. How will insurance handle this? I don't know. That's an insurance question. That's a good thing.
That is an insurance question, but I think the key there is that the physician doing the procedure has to document why it was unsuccessful and why it's needed again. And I think the physicians need to make the calls to this insurance company and say, look, and be an advocate for the patient.
And they're usually good.
Yeah.
They are.
And they'll respond to that, but you just have to document it.
And you know what? Sometimes I have people that they just don't clean out.
People have slow
They're
transit.
good people. They follow exactly.
And they're so heartbroken. They say, yes, I did everything you said. Some people just have a slow
And then there are people who are just clean as a whistle.
Yeah.
Osteoporosis, pressing on internal organs. What is a way to treat this? So bending over, osteoporosis, thoracic kyphosis.
That's a mechanical problem, and there's no good answer with regard to
There is no good answer, is there? You can't straighten them either.
No, not without breaking something.
45-year-old Aberdeen, stabbing pain in the left periumbilical area for over a year. Has been examined but can't figure out the cause. Recently has had loose stools, family history of diverticulitis. Any ideas? Sounds like diverticulitis to me.
The other thing I would be concerned about is you at least want to consider small bowel Crohn's disease. Anytime people point around the umbilicus, I think of the forgotten organ of the gut, and that's the small bowel.
Yeah, I would agree, and that might be the time to say, okay, a CAT scan.
Yeah,
With
with specific look at that small intestine, I think it'd be good.
All right, well, we answered 1,000 million questions. Thank you both for, it was wonderful. Thank you so much. Thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. Until next time, stay healthy out there, people.